Hi everyone, and thank you for joining us for the next section of our conference. We're now going to hear from a lady called Laura Hopestone, who's a chartered health psychologist and HCPC registered practitioner psychologist. And after an extensive career in oncology nursing, she trained as a health psychologist and has been working with the ocular melanoma field for over 10 years. First part of her talk will be looking at the sort of psychological responses to difficult thoughts, feelings, the uncertainty that can surround this, and describing ways of coping. The second part that she'll look at is what we don't know about the sort of psychological well-being, and looking at unmet needs in patients and people that are closest to them. So let me welcome Laura, and I'll pass you over to her. Thank you, everyone.
Hi, thank you. I'm just waiting for the slides to come up. Oh, here they are. It's like magic. Hi, so my name's Laura Hopestone, as Joe has said. Thank you, Joe, for inviting me to speak today. So I'm going to be talking about living with ocular melanoma. As I say, I'm the health psychologist at Liverpool Ocular Oncology Centre and clinical health psychology at Liverpool University Hospitals. I'm also a health psychology fellow in oncology, so a lot of my work is around research. And I also do work independently for OcuMel UK. So next slide, please. I was just sort of preparing this talk and thinking about it. And I gave a talk a few years ago, and I didn't want to sort of just go and repeat that. So this is slightly different. And I want to emphasize this is not just about the people who are diagnosed with an ocular melanoma, but it's for those closest to them as well, because it is difficult for everybody, for families, parents, children. It's a very tough journey. So I'm going to talk today a little bit about coping with difficult thoughts and feelings, and sort of very much sort of connected with that is anxiety and uncertainty. I'm also going to touch on some self-care. How do we look after ourselves and when to ask for help? The second part is a little bit around unmet needs, and some of the research that we're looking to do at Liverpool. And just wanted to sort of talk about that a bit, because we will be looking for representatives from the patient and carer community to support our research. Next slide, please. So I'm going to talk about, and I've borrowed unashamedly from Ross Harris and Ray Owens, who've developed a therapeutic approach called acceptance and commitment therapy. And I draw quite heavily on this model and with my work with patients. So I'm going to talk to you about how the mind works, and to see how we can perhaps change the way we respond to difficult thoughts and feelings. So essentially, the brain evolved to keep us safe. That's what it's there. It's to look out for danger. It's a problem-solving machine. It reminds us of important things in our past, and it notices when something or someone is missing. It also notices how other people respond to us. It notices threats, and that's quite important. It's the threats that often set off and trigger some very difficult thoughts and feelings and responses. So I'm going to talk a little bit about how the body responds to that, and perhaps how ways that we can help in that acute setting to sort of calm that all down again. Next slide, please. Okay. So your mind basically is trying to stop you from getting hurt. And if we go back to the prehistoric metaphor, it's trying to keep you safe. It's trying to save you from any pain. It's not defective. It's not abnormal. It's evolved to do this. It's about protecting the cave, protecting your family, protecting your tribe, and making sure that you've got enough food. The cave dweller mind, that's what they're there for, to survive against all odds and with marauding tribes and wild animals at the door. So a cave dweller mind prepares the body to run away or fight things like dinosaurs. So watch out, there might be a dinosaur behind you. You could get eaten. Look at that shadow on the horizon. That could be an enemy from another tribe. You could get speared. The modern mind doesn't have dinosaurs at its cave door, but it does have other things at its figurative cave door. And the modern mind will worry and catastrophize. What might happen? This might happen. All those sort of negative thoughts and predicting the worst. Because the cave dweller actually had to predict what might happen next. And that's what we're trying to do because we're trying to survive. And we also, in that kind of response, we need to avoid anything that's quite scary. You run away from things that are frightening, as our little chap's doing here. Next slide, please. So we have this internal alarm, this big red bell that goes off. When we sense threat, we sense danger. And it could be an appointment, a hospital letter. I don't know about other hospitals, but at Liverpool, we don't have a stamp on that says Liverpool University Hospitals Trust. But everyone knows damn well they can see when they turn over the envelope, the PO box, and the slightly off-colour paper that we now use for letters. So that may start to trigger a response. It may be an appointment or a scan date, something on the calendar that tells you that something's approaching. It could be information. Information comes from so many different sources now, and there's not often, there's the TV, there's ads, there's media, and then you might be on Google looking at something completely unrelated to what's been happening with you, and then something might appear. So this might set off that alarm. And also, and it's a bit like when you buy a green car. As soon as you buy a green car, everybody buys a green car. There's loads of them. When you have a diagnosis of cancer, one of your family members have a diagnosis of cancer, then you can often see it everywhere, and Macmillan ads are popping up everywhere, or they're on billboards as you're driving home. It could be a comment that sets off that alarm system. Someone might just ask, "How are you?" And perhaps you'd forgotten all about what was happening. You were aware, and then there's that reminder. It might be a memory, a thought, when there's no actual real threat, but something's triggered. Maybe it was remembering about a hospital appointment that you had a few months ago. It's often environments, like those sort of sensory symptoms, when we walk into, so a lot of patients, when they come back for their first follow-up visit at Liverpool, they will come into that clinic, and that might trigger those alarm systems because that's where they were first diagnosed. The people, the place, the smells. Another thing that can trigger this sort of internal alarm system and trigger anxiety and perhaps panic is some actual physical symptoms. And we know from our research that this can do this. This can actually sort of, turbocharge that sort of fear of cancer recurrence. But actually the signals that you might get, like maybe a little flashing in the light that you hadn't noticed before, or you've got some watering or a bit gritty, or your socket feels a bit uncomfortable. And that again might be a trigger to set off that alarm system. And functional problems, as we call them, which is sort of catch-all term for difficulty doing things. Walking down some steps and missing one because your depth perception's gone. Going to reach something and you miss it or spill it, or drop some food down you. That might trigger that internal alarm system. And then that's when it's basically the brain is telling you, you've got to get away from this, you've got to fight this, or you're just going to freeze. So there's a very physiological response going on, and it comes on so rapidly. And there's lots of different symptoms, and people do vary. And some people have one or the other. Might get the dry mouth, the rapid breathing, clenching of tummy muscles and hands. Some people become very dizzy because all the blood's rushing to the heart and to the brain. Everything's pulling away from the peripheral systems. You might get pins and needles, clammy hands, and then maybe that sort of pressure on your chest as though you can't breathe. Thank you. So what happens when we have this? We have behaviors, the fight, flight, or freeze, and they can manifest in different ways. So someone might be quite angry. Now, a cave person being angry is probably quite good because they're really angry, they're really fired up, they want to go and fight the dinosaur. There isn't the dinosaur here, but that anger might come up. The other thing people sometimes do, when they are feeling threatened is that they don't want to look at it, they want to run away. And it's avoiding people and places, reminders. So you don't get that comment or someone perhaps saying, kindly, how are you? But actually it might bring up that feeling. So people start to avoid things. Some people just kind of shut down and go numb. And it not the people do this sort of, you know, every time something like this happens. This will vary in different situations, different contexts. For some people, people will cry when they're really, really anxious and panicky. And what that crying does is actually it's sending a signal, is that I need some help here. And humans, we do seek help when we're feeling threatened and vulnerable. So we seek places of safety. And that might be our nurses and doctors. It might be our loved ones. It might be the hospital. The other thing we do when we're feeling threatened and panicky and anxious is we comply. We can't do what we're told, because we have to. And I think many of you might remember when you're first diagnosed, people are saying, well, go here, do this, open your eye, put your drops in, sit there. And then they take you down to theatre and, you know, give you an anaesthetic, and you just do it. You comply, don't you? Okay. So this, we're talking about that kind of acute anxiety that can really just come over you so suddenly. Often and you might not even notice the trigger. It might be just something very, very sort of just in the peripheral of your mind. But there it comes, powerful. So some of the things that I do with patients, to manage that acute anxiety, and those of you that have been under my care will probably go, oh, here she's going on about the box breathing again, is something called box breathing. And one of the reasons I like this is, is because it's quite easy to do. You don't have to count anything. You don't have to go in through your nose and out through your mouth or the other way around. All you have to do is keep the shape of a rectangle box either in your mind's eye or beneath your hand, which we place on the sternum. And you imagine the shape of the box and you breathe around it. And what that helps do is helps regulate the breathing, and it gets you to pull the focus of your attention onto the breath, slows your heart rate, brings your blood pressure down, and it gives you something to do. And sometimes people find this helpful, perhaps when they're coming for a clinic appointment, perhaps when they've gone to Clatterbridge and are having a mask fitted for proton beam, just sitting, waiting for having their plaque put in. So it's quite useful. And the good thing about it is if you don't do anything and you just sort of sit on your hands, no one can actually see you do it. The other thing I do with people along with this is some grounding, some present moment work. Now that can be done at home more than in the hospital environment because you don't necessarily want to focus on all the equipment. But if you're at home and you start feeling that panic or out in nature, it's about stopping and pausing and focusing on what you can see, hear, touch and smell. The other thing you can do in that anxiety feeling, you've got that breathing steady, you're in the present moment, is just relax down those shoulders, relax down those muscles in your tummy, wiggle your toes, rub your thumb across your fingertips, and just focus on the present moment, the here and now. Next slide, please. And these are for acute thoughts. As I said, this is the kind of acute anxiety when that alarm system's going off like mad. But it's not always acute. And as you will all know, that the thoughts will come and go. They will ebb and flow. And thoughts come in and out of our minds all day. We have around 4,000 thoughts a day. We don't engage with them, every single one of them. We wouldn't be able to do anything else. But it's how you respond to those thoughts when they come in. People often describe a constant stream of thoughts, a monologue of thoughts stuck on repeat, round and round, the what ifs, the what maybes, the should I have done this? What if I had done that? I'm not coping all right. It's self-criticisms, judgments, opinions. I shouldn't be feeling like this. And they're coming thick and fast. And it's the difficult thoughts and feelings. And as I've said before, the brain wants to get rid, push away or solve, find a solution. Next slide, please. But thoughts are sometimes useful, and they're useful when they can alert us to something that we need to do. They're a cue to action. And it might be, yes, phone up the GP, phone up the hospital, ask someone to do your shopping because you're not feeling up to it, pay a bill. It's a cue to action. These are useful thoughts. We'll have them. We need to do things and we have to get them. And some of the things we don't even really think about, right? I must need to put the washing on. You don't go backwards and forwards too much about, oh, should I put the washing in? It might be because it's raining, but you tend to go, okay, yeah, do that. But it also can remind us to look after ourselves, to remember to pause and do our grounding exercises if we can still feel that anxiety rising. Thoughts are helpful when we need to seek help. Is there a troubling symptom? You're thinking, hold on, this isn't right. There's something going on here. Should I seek help? Or ask another person's point of view about something. It could be about anything. It might be related to what's wrong with you. And also it can cue us to seek information. I need to find out about this. I need to find out about that. And that's good if you can find the information that you want, but often you can't, because often the signposts and pathways aren't very clear. Next slide, please. So it's how we react to these thoughts and feelings that sometimes gets us into trouble. We can dwell on the past, we can go over things, we can ruminate. Why hadn't I done that? Had I noticed this sooner? I wish I'd been a better person. I wish I'd been kinder to that neighbour. All those things, we can go over and over them. Or we try to problem solve and find a solution. And often we can't find a solution because humans, we want clear answers. But often, as you will all know, there's often not clear answers, clear pathways. This will happen and that will happen. That cause and effect doesn't necessarily happen in the way that you want it to, because we like that. We like to be able to plan. It gets us into trouble, as I said, when we want to avoid things. People that evoke those thoughts find it too much perhaps to be in a social situation when people are asking you how you are or making comments, oh, I've not heard of that before. And again, we might want to get rid of those thoughts. We are trying to push them away, or we try and have a fight with them, and we get caught up with them, we get hooked on them. And does it work? Does it change anything? Next slide, please. So there are comments coming through, but I'm going to try and address them towards the end, if that's okay. Okay, so I want to just show you a couple of sort of metaphors, and psychologists love metaphors, and we like visualizing things because I think we want to be able to deliver a message to someone about what we're suggesting they try and do, and it's quite hard. So we do like a nice metaphor and an illustration. And this is something called the beach ball metaphor, and this again has been taken from ACT Auntie, which is the acceptance and commitment therapy group. So it's very natural for us to want to push difficult thoughts and feelings and emotions away. Thoughts, feelings, emotions, they're all bound up with each other. So if you visualize that as the beach ball, we're trying to push it away. And if you've ever tried pushing a beach ball down, as soon as you let go, it just pops up at you. It doesn't make it go away, and it can make things more difficult. But you don't have to like them or want them, and you might wish that they're not there. But could you be willing to allow them to be there so you can get with what really matters to you? So that's one way of looking at difficult thoughts and feelings. And this is another one. Next slide, please. So this is, and again, some of these won't chime with you. Some of you think, oh no, I can't get that. I don't get that. That's fine. It's a little bit of trial and error, and it's not going to work for everyone. It's not a one size fits all. I have to sort of modify these things for individual patients. But if we think about the monster, and here's the monster, and it's called the tug of war metaphor, and you can see why. Here's the monster, and the monster's got all sorts of things. He's the anxiety monster, the self-doubt monster, the sadness monster, the I'm not getting it right monster, I'm not good enough. It's all these things. I should be coping better. And what we do is we get into a fight with this monster, and we're pulling on the rope. And in between you and the monster is a big pit. Now, I did use this with a patient. The pit was full of snakes. And she said, well, I don't mind snakes because I could get out of them. I went, okay. So we had to modify it, and we modified it to basically sharp shards of rock, because she said she knew she'd get impaled on them and she wouldn't be able to get out. So we're pulling on this rope. We're pulling on this rope, and the monster's pulling. I've got to ask a thing to do. It's actually just to put the rope down. We can drop that struggle. We can drop that fight. And what the monster will probably do is just wander off. Now, we might come back. We probably will. Difficult thoughts and feelings do come back, don't they? And they ebb and flow, they wax and wane, and sometimes they're extremely powerful. It's when we get hooked by them and we start pulling on that rope that we get into trouble. Next slide, please. Okay. So, and closely related to this, it's around sort of, uncertainty. It's uncertain thoughts, uncertain futures, what's going to happen next. And often humans prefer certainty. I need to know what plan, so I have some control. And we find this in the work that we've done. We've done quite a lot of research in people and their decision-making processes around accepting a prognostic biopsy for those people with choroidal melanomas. And there is that drive, I really need to know. And this is what people are saying to us. But even when they get a definitive result, it's not a foregone conclusion. There's always going to be some uncertainty. And there's uncertainty in everything. We don't know what's around the corner. And I think in the last few years, I think that's, we found that out, didn't we? When all of a sudden we were all locked up and we didn't know that was going to happen. And things were very uncertain for a long time for lots of people. When am I going to see my family again? Am I going to be able to get to my hospital appointment? Will my scan be postponed? So there's always going to be uncertainty. And as I say, it's come in spades recently. So maybe it's about learning to live alongside it and being open to good and bad days. And some days the uncertainty is troubling. But for some people, and we found this in some of our studies, that uncertainty can be a place of solace and hope. And what do I mean by that? Is that people, sorry, I just noticed I'm getting a few, I'll try, unfortunately I live in a forest, so it doesn't always go as smoothly as I'd like. So for some people, uncertainty is a place of solace and hope. And what I mean by that is, it's not a foregone conclusion. We don't know what's going to happen next. So people can find that quite reassuring. Next slide, please. So when we talk about responding to thoughts differently, reacting to them differently, it's about acknowledging and noticing our thoughts and knowing that we can actually hold different emotions simultaneously. And in acceptance and commitment therapy, we talk about acceptance, not in resignation. And people talk, I haven't accepted this, or I have accepted that. But it's accepting and allowing difficult thoughts and feelings, powerful emotions to come and go. It's allowing them to exist, but not to consume and overwhelm. And the goal in this therapeutic approach is not to reduce the thoughts and feelings, but enable the person to do the things that matter in their life, in the presence of those experiences. Next slide, please. So I mentioned about good and bad days, and I think, so many people use the word roller coaster because that's what it feels like. And sometimes the ride's a bit smooth and then it goes up and it down, and very much at the beginning. And we can latch on and get hooked by those negative thoughts. And that's where we can use the tug of war and the beach ball. around making space for, as I say, accepting and being in the present when there are good thoughts, emotions, and experiences. And this might not chime with everyone, but when I hear this song, I think about it. I think, when you don't need to worry, there'll be days like this. Next slide, please. So, another metaphor, as I mentioned, like metaphors. So this is the growth metaphor from Tonkin in 1996. And it was kind of evolved from work with people who were grieving. But the ball really that you can see in the jam jar could be lots of things. It could be uncertainty and fear. It could be distress and anxiety, a diagnosis of cancer for yourself or your loved ones. And it sits there like a big ball, and it can feel very big and take up a lot of your space, especially at first. And a bit like grief for people, for those of you who've been bereaved, that's what it feels like. It's so large. And there is this notion that perhaps the grief shrinks over time. But what Tonkin has said is actually, it's the other way around. The ball itself will stay the same. That diagnosis hasn't gone away. That loss hasn't gone away. But what happens is we learn to grow around it. And we can grow, and it says there, grow around our grief, grow around our uncertainty. So the jam jar basically gets bigger, but we still hold it there. Next slide, please. So I'm going to say, I mentioned around self-care. I do hope the connections, and I say, is as good as it can be. And there's a bit of a storm blowing out here as well. When you're in pain and suffering and feeling scared and vulnerable, you kind of should really be kind to yourself. And when I say to patients, oh, you know, self-care, self-kindness, and some people said, you know, I don't really know how to do that. Perhaps you're one of those people that's always been looking after somebody else, meeting everybody else's needs. You're really not used to looking after yourself. And humans can be quite hard on themselves as well. I should be this, I'm not as brave as so-and-so, and she got cancer, and look at what she was doing, and I'm not like that, so I'm somehow weak. Would you want a friend to say to you, oh, stop whining, pull your socks up, stop being so weak, you should be handling this better? We don't want that. But we say it to ourselves, don't we? So it's perhaps trying to treat yourself as you would a friend. I'm not surprised you're struggling after the year you've had. You'd say it to a friend. Try saying it to yourself. That's really quite hard. And asking for help and accepting help is actually a way of self-care. And if that doesn't come naturally to you, as I say, if you've been the one that sort of organises everything, is always there for everybody else, and suddenly you don't feel in the position to do that, but you want some help. And it sometimes takes some practice. And self-care does take, it might be having that bath with the candles, or binging on Netflix, or going to yoga, or going for a walk in nature. But it's also about expressing emotion and telling other people how you feel, because actually they can't mind read. Next slide, please. So asking for help, and there's so much research and evidence about the value of peer support. And yourselves here in OcuMel and Maggie's and Macmillan will say the same. And generally, people with cancer often prefer self-help, self-guided help. And not everyone wants or needs psychological support one-to-one. But support needs to match need. And often there aren't clear pathways to sources of support, which can give rise to unmet needs. Next slide, please. Oh, can you go back one, please? Thank you. Okay, so this is where I was going to come on to unmet needs. And what they mean by unmet needs. So these are unmet supportive care needs, and they're defined as care that helps patients cope with cancer and treatment, which are not addressed and require additional service or support. So it might come as no surprise to you all that people with rare cancers do have more unmet needs and have inequitable healthcare compared to those with common cancers, because they're rare. Fortunately, they have lower survival rates, poorer quality of life, and higher levels of stress compared to people with more common cancers. They often face difficulties with incorrect or delayed diagnosis outside of specialist centres due to the lack of clinical expertise. And there may be people amongst you here that have had, struggled to get that referral for whatever reason. Also, people with rare cancers find accessing relevant information more difficult than those with common cancers because there's so much out there about breast and prostate and bowel and lung, but not conjunctival melanoma or uveal melanoma. And geographically, you can feel quite isolated because, the Ocular Oncology aren't the only specialist centres. There'll be specialist centres for rare sarcomas and other types of cancer. And also, you probably won't come across somebody in your everyday life who knows somebody who has the same diagnosis as you. Okay, next slide, please. So this is a study that was done by De Hoos last year, and she did a systematic review. So that's looking at all the studies, looking at unmet needs that exist for rare cancers, and she pulled them all together. And the findings are quite unsettling, aren't they? There's 95 patients had unmet healthcare and information needs regarding side effects, long-term impact, cosmesis, and returning to work. And a similar proportion had unmet needs in relation to fear of cancer recurrence, coping with uncertainty and feeling anxious and depressed. And 80% of patients reported unmet needs such as difficulty resuming normal activities. There's two studies on unmet needs, but the Williamson one is the only one that she reviewed because it met her criteria for the review. What was found is that psychological needs, including physical disability or deterioration, and that compared with newly diagnosed patients with breast and prostate, patients with had a higher proportion of unmet needs. Next slide, please. And I think one of the problems with ocular melanoma, conjunctival melanoma, choroidal melanoma, it's often the information that you find out there is not relevant. It often relates to melanoma in general, skin melanoma. I mentioned about geographical isolation, but another problem is that it can expose health inequalities. If you've got to travel to a specialist centre that's 200 miles away, that's going to cost. Bertil D'Amato wrote a paper back in 2020 sort of, highlighting this, that actually there's been a significant barrier to accessing healthcare, even when there's clinical need. And we know that a lot of patients will be discharged back to local services, but initially they will have to travel to the specialist centres. And whilst there may be some help for some people, in Liverpool, we do put people up in hotels, but it's still the travel. Maybe there's childcare costs, there's time off work if you're self-employed. So there's often a financial cost to all of this. The other aspect of unmet needs that are not obviously met is around health literacy. Now, I don't pretend to be an expert on this at all, but basically this is the ability to read and act on written health information, communicating needs to health professionals, and understanding health instructions. Now, when you come into this that there's a lot of jargon, there's hospital systems, and some people have for, and then you've got so much specific and complex stuff to take in. And, we know, and patients say it to me all the time, there was just so much information coming at me. I couldn't take it all in. And that's for someone perhaps whose reading and writing skills are good. But if someone who has difficulties, that's going to be a real problem. Okay, can the next slide, please? Can I have the next slide, please? Thank you. There's also, and this is highlighted by Correa, are following on from the Williamson paper, and it is a problem, isn't it, when people are discharged to local services, or perhaps having alternating local service with specialist centre, depending on what's happening. And a lot of our patients, nucleated patients will tend to be discharged sooner rather than later. At Liverpool, people have to wait until the risk of low recurrence is low enough before we discharge. But what Correa has said is that general ophthalmologists overlook or do not always appreciate the profound effect of a cancer diagnosis on the patient and their family. There's also the lack of access to expertise and knowledge. And one thing that with some of you is that, you know, battling to get scans, it's like they don't really understand why you want one, because they're really only thinking about the eye and not the problems that may occur in the future. Next slide, please. Okay, so what do we know already? And what we've done at Liverpool, we do a lot of psycho-oncological research, particularly in ocular melanoma. That's part of my post. We've learned a lot over the years from large population studies, but also the smaller qualitative studies. So the population studies, we're looking at anxiety, impression and mood, and we found that actually, you know, generally speaking, patients can maintain a good quality of life and mood, much the same as the normal, in inverted commas, population. Most recently, we've published a paper written by Carrie Davis around predictors of distress. We wanted to know, you know, what do we need to be alert to? And we found that, and this is again, it's a systematic review, so it's taken all the evidence from all the studies that have been done. There's not that many because, again, rare cancer, less people, less studies, less research groups. And to manage expectations post-treatment and help patients realistically appraise symptoms. So why I'm saying that is because often we found this in a lot of our work is that people who experience visual and ocular symptoms, and ocular symptoms and functional problems, sometimes that will spark that fear. Is this the cancer coming back? And makes them think about it. It makes them think that something really bad is going to happen. So we have to be alert to that and understand that. We know about phantom eye syndrome, some of the work that we've done, and we've looked at changes to patient information, and this informs psychological intervention, especially when we can identify triggers such as stress. What can we do to help manage that? And that's something I can work with people with. Also, it's just finding out new things. You know, a noise might set off a phantom eye symptom. If nobody's ever told you that, you're not going to know, and that might actually be quite distressing in itself. The qualitative work we've done around uncertainty and decision making, we have found that a definitive prognosis does not necessarily alleviate uncertainty and can create more uncertainty. So my role is to help people cope with and tolerate that inherent uncertainty. So that's what we know. What we don't know, we probably don't know an awful lot. And we were thinking about this and about unmet supportive care needs when we were looking at that review. And it's not just the patients, it's the people closest to them. I'll come on to that in a minute. We don't really know what the form that the support should take. We know that patients prefer self-guided management. And not everyone wants or indeed needs one-to-one psychology input. Peer support is great, but not everyone can or will access that kind of peer support. So we need to kind of find out what, when and how to meet unmet needs, but we kind of need to characterize those unmet needs in the first place. And we have been toying with different ideas in terms of funding streams for grants. Next slide, please. I mentioned about it not being all about the patient, and I just wanted to, and hopefully this talk is spoken to everybody, but some of the research has found, and this is why we're keen to investigate it further, is that there's lots of words for the people who support people, carers, primary support people, family members, those closest. The term you use is you can prefer yourself. They often feel neglected, and yet they're involved with supporting patients in everyday activities. And the effects of caregiving can negatively impact on quality of life, mental and physical health. Carers, family members are often reluctant to attend to their unmet needs as not a priority, and they might actually be needing to go and see somebody about a physical symptoms, but think, no, I'll just leave that be. Let's get my family member sorted. They might avoid reporting them as they are focused on the patient's well-being, and as I said, put their needs over and above their own, or may not feel they have legitimate needs. And one thing that has come out of some of the research, and there isn't much, is that they often feel left out of conversations, sidelined, not listened to. Next slide, please. So I mentioned about exploring unmet needs. We're not quite sure exactly what form this is going to take, and these are some of the ideas that we're talking about. And I say we, it's to say the Psycho-Oncology Clinical Research Group at the university. And we aim to characterise those unmet needs. We don't know what they are and when they are. What happens at 6 months, 12 months, 24 months? We know from our population studies that things will change, vision will go. In proton beam patients, we're talking 12 to 18 to 24 months. So we need to find out what type of support and when, and we need interventions that we can test and evaluate. And as I mentioned, patients often prefer self-help, self-guided, and we need to broaden that access. Next slide, please. So this is one idea that we were thinking about putting in a grant application for the NIHR for research for patient benefit. And in fact, any grant we apply for, they do want, and rightly so, patient and public involvement. So that will be something that I will be approaching OcuMel about, because we need the people who can tell us what their unmet needs are, rather than us sort of second guessing. Next slide, please. And one idea that we do have, and I know that some of you have contributed to a version of this, so thank you for that. We were thinking of developing a guide to living with ocular melanoma for patients and those closest to them, to look to further develop and test it, as I said, and to try different platforms out, podcast, video, written. We need to be able to test its effectiveness, its usefulness. Does it change over time? Does it reflect the changes over time? What is missing, and does it address unmet needs? So these are ideas we're toying with. As I say, we're looking for funding. We haven't got a firm plan yet, but it's going backwards and forwards to a considerable degree. But as I said, we will be looking for patient care representatives to advise on the study. Okay, next slide, please. So this brings me to the end. I will ask, I'm not quite sure how I'm answer the questions. I don't know if Joe's going to sort of facilitate, but any questions and thoughts and reflections?
Brilliant. Thank you, Laura, as always. Yeah, I'm quite a visual person, so I find it useful just with all the analogies that you bring and show. So thank you for that. I think it is difficult, and you've touched on before that there is this unmet need in this cancer, isn't there? And we heard from our patients earlier, obviously, that they don't look ill, and I think sometimes that can be difficult as well to sort of understand and sort of process and sort of feel that actually that's happening to you, or to somebody that you love, and sort of how to approach that. So yeah, I think it's just good to think about. For sort of family members who are supporting people with this condition, how is there a right way to sort of support people that you love when they're going to go having this diagnosis?
Well, I suppose I think, as I say, that patients can often support their family member in ways that, and even if it's like, what can I do to help? And often they can feel quite helpless, because they can't make this go away. But I suppose it's helping them say, well, actually, what would be really helpful is this. And it might be practical stuff. It might be emotional stuff. I just want a hug. Or could you field all those WhatsApp messages, please? Because they might be coming thick and fast. Or could you, open up Clatterbridge, or I don't want it always to be. So the person can help, and so the patient can help the person. I suppose it's, as professionals and in clinics, it's making sure that is when they have that diagnosis, that they're involved in that and are invited to ask questions. And I suppose that's another reason for us wanting to look at patient, family members, carers, whatever you want to call them, as unmet needs, because we actually don't know. And there's an absence of evidence, which is why we're interested in doing it. But I'm not sure that answered the question. But anyway.
Yeah, no, I think it's just people know their loved ones best as well, don't they? That actually, whether it's cancer or whether it's just that they're having a difficult time through work, it's just the way to support somebody, and sort of, I guess there's not a wrong, there's not always a wrong way. It can try something, see if it works, and kind of adjust possibly.
Yeah, I mean, it's strange because and often you won't be on the same page as your loved one, and sometimes you will. And actually one day the patient might be feeling quite upbeat and everything, but the other person isn't. And I suppose it's that communicating with each other. As I've said, you cannot read each other's minds. You have to let people know. And that's hard for people. As I say, it's the person who's thinking, I shouldn't be feeling all strong, because if I fall apart, everyone else was going to fall apart. But then they're showing an emotion. And again, it's those thoughts and feelings, then come, let them go. There's a question, Joe, in the chat. I'm not sure that you've seen, from Nikki.
So she mentions since diagnosis, her GP's been overzealous with urgent referrals. How could she cope with that emotional stress?
What I'm not quite understanding the question. Who the GPs refer?
So I think, we sometimes hear about this a lot in the helpline, is that you find a bump, you get a new mole, you notice, you take photographs every other week possibly of something. Just everything, always your first thought is cancer. It must be cancer. Right. So emotionally, how do you sort of level that out, that actually this can be something normal? I'm presuming, Nikki, just correct us in the chat if we picked up the wrong end of the stick there.
I suppose there's, to address what you've just said, Joe. So that's called threat monitoring, and people do it. Every bump, every lump, what could this be? Yeah. And it's about pausing. Have I had this bump before? Is this new? Is it changing? Has anyone else noticed it? And it's supposed to be realistic, appraising those symptoms, and that's quite hard. If it's what it may be meant as, that the GP is anxious. Yeah. And often we have to, when we find this a lot with sort of clinicians, it's their anxiety. He doesn't want to, or she doesn't want to get it wrong, because she knows you've got this cancer already. Is this going to be something else? And so how can that person cope with the emotional stress? Well, that's something, it's around perhaps, looking at emotions, thoughts and feelings differently. Or perhaps just saying to your GP, actually, this is making me very anxious. But obviously, Joe, that in my work, that's something we would work with on a one-to-one basis if it was becoming a problem. And that they can access the service, and Joe will can facilitate that if needed. Yeah.
And it must be difficult for GPs, because obviously this is such a rare cancer. So they're probably feeling that they're doing right by this person, obviously by looking after them. But it's just difficult getting that balance. And yes, patients from Liverpool can obviously access you through you and your team through the NHS, and members can come via us and get support as well. So if that's anything that people would benefit from, please head to our website, ocumeluk.org/support, and then that will direct you on how you can book sessions with Laura. We do have a few sort of comments coming in. Let me just check that I get the one from the top. Somebody has hardly ever spoken to their GP since their diagnosis, and the oncologist has taken full control and obviously been referencing my GP, but the GP hasn't been involved so much. Is that something that you hear about quite often?
Variable.
Or does it vary? Yeah.
Absolutely. I hear everything from GPs being really on it, phoning patients up, putting them on a pathway so they can see a Macmillan nurse, and other ones who have taken no notice at all, and then all the bits in the middle. I think if you've got an oncologist looking after you, then the GP doesn't actually have to do anything other than read the letters. And if if there is something the GP needs to do, and if you get that letter from the oncologist and you can see it's copied to the GP and they're asking them for something, then that's something you probably need to chase yourself. And I think we all know that we do have to chase these things.
Yeah.
Okay.
Good question from Carol. Why is the emotional baggage so exhausting?
It's all that fighting with those thoughts and feelings, isn't it? Draining. And that's where the kind of, I suppose, the work that we can do around responding to thoughts and feelings differently is helpful. Because yes, it ties you out, and it stops you living the life you want to lead because it drains you of energy.
And sometimes it's not until you've kind of started to come through it that you realise how exhausting it's been.
Yeah. When you've had all that adrenaline pumping through and all that acute anxiety that I talked about, it's just flooding with adrenaline and cortisol and all the rest of it. And it's like, remember when you were young and you had an exam and you fired yourself up and you'd feel completely exhausted afterwards. And often people feel that and they're drained and exhausted. And that's when those sort of underlying emotions can surface, not that acute anxiety, but maybe that sadness, loss, and that can feel quite heavy. And
quite normal.
Yes, that's absolutely point, Jo. Absolutely, yeah. No, wholeheartedly, and that's it's not wrong. It's okay. It is normal. It's when it's stopping you from doing things and getting on your life, then that's where we need perhaps a little bit of intervention here to move people along.
Because also just everything can be so fast, like so much faster nowadays, can't it? It's rare on an evening where you just sit down and watch TV and without sort of feeling pressure to be doing something else whilst watching TV.
And that's that self-care, isn't it? That self-kindness, turn your notifications off, go and watch something daft, please do. Allowing yourself to be in that moment.
And kind of we talk about just initially just taking one step at a time, so much is happening, but actually when something then changes, if you start having trouble with your eye or you need further tests and things like that, they're all kind of triggers, aren't they, sort of in that process?
Yeah, as I said, I mean it's obvious, isn't it, really? They may trigger those again, and you might get worried. And that was the way when I was talking about living with this, is around accepting that there are going to be days that aren't good, and there's going to be days that are good, and there's going to be scans and appointments. It's going to happen. So what needs to be able to help respond slightly different to perhaps some of those very powerful thoughts and feelings, which are completely understandable and proportionate. It's when they stop us living our lives and engaging with the world around us, then that can be probably needs a little bit of help there.
And just for sort of like timescales, you mentioned obviously that you're looking to do some more research into the effects of all of this. I mean, we can obviously keep our members notified and things like that. So it's great to hear that you value that.
We absolutely want you and need you on board. Want you on board. So yes, we
more than happy to help.
Thank you.
Brilliant. Well, I think we've got one more. One more possibly. Yeah, I think there's just the one more from Sue, just to say thank you to Laura for both her talk, but mainly for the incredible work that you're doing to support OM patients with unmet needs. Just that desire, actually, that it's a shame that it's not something that everybody can tap into as routinely, which I think is where sort of like our service came from, is, obviously we felt that was really important to people as well. So, if you're listening and you'd like some time to talk, obviously you can book through us to book some sessions with Laura and her team for you and family members, if you're not already being looked after by the Liverpool team already. And then we'll hear, shortly about the sort of services that Maggie's can provide. So you know, because there's all different approaches, isn't there? And just
absolutely, yeah,
you know, I think all of those other sort of, you know, signpostings to all the different areas can be really useful.
It's about meeting people's needs, and part of my work is to signpost people if necessary, if I'm not the best person to meet those needs.
Perfect. Oh, brilliant. Well, thanks so much for your time today, especially for sort of giving us such an in-depth talk on it. And yeah, I'm sure we'll have you back again, and hopefully doing this in real, you know, in person. Sort of
yeah. And just how do you get
soon?
Okay. And how do I listen to the rest of the talks?
You'll be given a link, and then you can join us for the rest of them.
All right. Thank you, Jo, and thank you everyone for listening.
Thanks everyone for the comments. Thank you. Bye.
Bye bye.